I think at this point, because we're short of time, can I ask the four speakers from this afternoon, Mike, Wei Shui, let's see, Peter Shaw, and James, to please come up. Do you want to put out name tags? Okay, and then, yeah, people can ask their questions and we can have panelists discuss them.
They moved.
Let's see, who was next? I'm not sure.
I don't remember.
Just
over there.
Go ahead, I guess.
Well, I have a number of comments, and one is that let's be very clear what the law says. For the criteria pollutants, the law and the court cases indicate that you're to protect the most sensitive persons. Now, EPA has interpreted that to mean the most insensitive groups. That is not one individual. But I have to say, with regard to Dr. Dorson's comments, don't use this word hypersensitive. It's politically loaded. It's not a word which appears in the law. And it's part of the armament of people who argue against people who have chemical sensitivity. So I would personally appreciate your excluding that from the dialogue. Nobody's talking about protecting hypersensitive people. The law says sensitive groups, sensitive individuals. And by the way, there is no basis in the law to establish a benchmark level of protection based on some idea of acceptable risk, which is part of the last speaker's imputed discussion. As far as the non-criteria pollutants is concerned, the law is very clear. You don't set the level of protection based on risk assessment. You set it on the basis of what technology can achieve at the average of the best 13%. So, we're not doing that. And nor is cost-benefit analysis a relevant factor in the setting of standards. It's relevant to OMB, who wants to cool the rigors of regulation by forcing people to do this. But the court cases, again, are very clear. You cannot use the excuse, I'm not ready to set a standard because I've got to do a cost-benefit analysis because Mr. Sunstein decides that's what's necessary. We've been Republicans so long that I think we forget what the law says and what EPA is obligated to do. Mm-hmm. And to find federal employees capitulating to this view is disturbing to me as a teacher of toxic law and as a long-time observer of the regulatory process. I mean, generating an acceptable level of risk is not in the law. And that's not yet what Congress has asked us to do. And the one word which seems to be missing from this whole discussion is the precautionary approach to protecting populations. And yes, I appreciate the complexity of multiple endpoints and genetic variation, and all those things are extremely important. But as I will say tomorrow morning, I think we've lost sight of what the purpose of the regulatory initiative was. And that is not to bend our response to the current political pressures, but to do what the law says we're required to do.
Ed? Good.
Go ahead.
Just real quick. The idiosyncratic or hypersusceptibility are the medical terms, at least I'm thinking, that we use and other groups, health organizations around the world use to say that the reference dose or minimal risk level or TDI or whatever acronym you want to use don't really cover those. However, if there are different to get that concept across. But if there are different terms that can be used for other, because they're impugned somehow by other groups, I'd be more than happy to talk with you, Dr. Ashford, about what to use. That's fine.
Yeah, there's some cases like when I was on the copper committee, we found that for people with Wilson's disease, background levels of copper that are essential for diet are too toxic for people with Wilson's disease. However, there are people the committee was concerned about people who are heterozygous for Wilson's disease and whether they might have some environmental sensitivity to copper toxicosis. And that was the chronic endpoint that the committee considered, not just acute gastrointestinal upset. So there will be instances where you're going to get into competing issues, and it's not always easy.
Thank you. That was a great lead into my question, which is about whether or not any of the people here involved in risk assessment at EPA or elsewhere have started having conversations about how to handle the risk assessments for endogenously produced compounds that are also exogenously either inhaled or ingested. Copper isn't endogenously produced, but it's obviously vital. I'm thinking more of the gases, CO, NO, H2S, the list is growing. These are all biologically active at a very low dose range, and right now the standards seem to assume that there's a gap between that level at which they're endogenously bioactive and the level of exogenous exposure that might interact with that endogenous activity. And it seems we need, from my perspective, a whole other paradigm. I don't know what it is. I want to know if any of you are aware of discussions about what type of paradigm might be developed for endogenous substances.
Okay, so in the case of essential elements, you have your U-shaped dose response curve, and there's been a real good study by Dan Krusky and colleagues on a U-shaped dose response curve done by categorical regression, trying to match the adversity on both sides of that U. So that's a good way to go forward. But I think the short answer to your question is that risk assessors routinely consider endogenous exposures and should fold that into their discussions of risk assessment, or at least discussions of uncertainty in whatever number they wring out of the assessment. You really have to approach that front and center. Now, is there a different paradigm to go forward? Well, maybe there is. And I guess I would defer to other colleagues that have actually grappled with those.
So far, I note that EPA's risk assessments about chemicals that have this nature, like NO and CO, have not addressed it. The assumption is that I presume that there's some middle range between endogenous and exogenous where presumably this is a safe threshold for all of us.
Well, it might be in the fact that the incoming data, epidemiology or experimental animal data, had as a basis in the control groups that background exposure, and therefore the reference dose or whatever it is added to that background. I mean, that could be it, but that should still be discussed.
Okay, thank you.
And if you get safe doses that are lower than background, that has to be discussed as an uncertainty.
All right. Anybody else? EPA?
I guess I'm not going to respond directly necessarily, but I think in situations such as with essential nutrients, and I remember Dan Krusky saying that in finding that whatever standard you set, some people are going to have an adverse effect from because of one direction or the other. So actually bringing it back to the topic of this workshop, human variability really is sort of integral to that risk characterization. And I don't think that we have a good way of figuring out how that informs how decision makers will utilize that information in their decisions. I don't think that there's a good appreciation for that. I think, and I'm speaking for myself, not for the EPA, that there's still a mindset of kind of a safe, not safe dichotomy, which I think is a false dichotomy. And I think all the epidemiologic data, those data-rich chemicals show that really it's a continuum of level of effect, and maybe moving away from, as I think you alluded to, moving away from sort of the fixed benchmark response, but looking at the continuum of dose response, and then trying to characterize that across the human population might be one way one way forward.
Let me just interject that we need to end at about 5:30 here, and that tomorrow we'll have a lot more opportunity to talk about regulatory implications of individual variability. So today, while we have these speakers here, please take advantage of their areas of expertise and their presentations in your questions. Thank you.
There was a reference made to susceptibles dying out, but I want to point out with the xenobiotic metabolism pathways, the variability is preserved in most advanced life forms, and this is the diversity in the human and advanced life populations promotes species survivability in a changing environment over geological times. So these are not genetic defects. And let me close by saying a quote from Sheldon Samuels, failure to consider sensitive subpopulations as social as opposed to natural selection against those individuals. Thank you.
Comments? Well, we have Dr. Shaw here. I wanted to ask him about this use of the terms, sensitivity and intolerance. And I know in the field I come from allergy, if you're talking about an intolerance, you're talking about something where there's no clear immunologic basis, at least not as of yet. And a sensitivity implies some immune kind of involvement. And the parallels between drug intolerance and chemical intolerance are so strong that I think we may want to use our language very carefully in this regard. And I'd ask for kind of his thoughts on that.
Well, I think, use of language is critical. I know that certainly from some of the examples I put up there, we absolutely know that the immune system is probably involved in many of the what we would call serious adverse events that we talk about, DILI, other ones, and most of the genetic factors we find through these associations are pointing at the HLA system for starters. But I think sometimes language is critical for people to understand that they're talking about the same thing. I don't know what else to add.
Mm-hmm. Yeah. So what we see patients reporting is they've lost tolerance for things that formerly they tolerated. So it's almost like a diabetic losing tolerance for sugar. And you wouldn't call that a sensitivity, So this is important. And I guess we don't know all the mechanisms, but I think this is parsing out to be a very important question. Thanks.
This side.
Hi, there was a reference earlier to not trying to set a standard to protect the jogging asthmatic was the derisive term used. And as someone with asthma, I found that slightly offensive. I also thought it was contradictory to a lot of the science presented today, where diabetes and obesity are major modifiers for air pollution health risks. And the best way to control diabetes and obesity is diet and exercise. And so if the regulatory framework is sort of aligned against encouraging exercise that's cheap and affordable for communities where the people who are afflicted with diabetes and obesity are often the same communities afflicted with environmental justice issues, I think maybe you should consider encouraging jogging in the asthmatic and setting the regulatory thresholds at that level. And I was wondering where that phrase came from. Was that actually something somebody had said previously, or was that introduced at this session?
So I was the one that made the comment. And it was actually a quote from the EPA administrator when the original ozone standard was set. And it was to say that the law, as it was stated at that time, allowed us to set a level based on cost benefit and health issues that in fact was not going to protect the jogging asthmatic based on the way the law was written. But that he wanted to be very clear that that was the case so that other things, like the use of ozone determinants for a particular day, or the fact that medication should be available at that particular time, was something that was part of the solution. So it was not meant to be derisive, but the point was that this standard is not going to protect that particular group. And it was a statement from the EPA administrator.
Yes, Joel?
if I could just add to that, part of what went into that was also the severity of the event, right? If those jogging asthmatics were having heart attacks instead of asthma attacks, I think the decision would have been different, right? So it was, a statement that given that this was a reversible temporary effect that would happen to them, and infrequently that the administrator wasn't going to drive the standard that low to protect against that. So it was this sort of part of this argument over what constitutes an adverse effect and how adverse it was.
So I just wanted to address the question, I think, to Jim and to Peter. In both of your cases, I think what you talked about was the idea that we could do some testing in parallel. In other words, as you're beginning to look at traditional drug testing development, or as you're doing traditional epidemiologic studies, we ought to be looking for studies that, as we identify modes of action or targets, we collect additional data. And I guess I'd like to think about that in terms of our environmental risk assessment issues as well, and whether that doesn't give us some clues for how we might do our toxicology and safety testing for environmental agents as well. We should comment on that.
I think we need to wrap up.
Can we let Jim speak? Because I think he didn't get the same thing. And after that, we all have to cut it off.
So I concur. I think one of the problems that we had is, as someone mentioned, looking under the light post, and we've been doing too much of that. In the old days, it was much too expensive to do everybody's genome. It was much too expensive to do metabolomics, broadly speaking, or proteomics. But the technologies are driving it. And I like to think that I really don't know how to explain physiology. So I'd rather have the data to try to give to the modelers and the statisticians so that they could help me interpret what we see. So our view is we need more data with better defined systems and deeper data.
Thank you, everybody.